Great. Well, thank you everyone for joining. It's Michelle Calero. I'm the new Executive Director for Bladder Cancer Canada. So we're so glad to see you here. Also joining me is Shasa Boshoff, who is our National Fund Development Manager, and Teresa Blondin, who is actually our new Manager of Volunteers and Community Programs. And most importantly, we've got Dr. SrikalaSridhar here to talk to us about advanced treatment innovations in bladder cancer. And just to give you a bit of Dr. Sridhar's extensive experience, she's a professor in the Department of Medicine at the University of Toronto and is a medical oncologist at Princess Margaret Cancer Centre. She's also the vice chair of our medical advisory board at BCC, which is fantastic. She does a lot of work for us and we're very appreciative. Her main area of interest is in new drug development and phase 2 clinical trials. And she's recently published in the New England Journal of Medicine. And in 2011, she received a postgraduate medicine teaching award. And in 2020, she was awarded the University of Toronto Department of Medicine Robert Hyland Mentorship Award. So Dr. Sridhar, we're so happy to have you, and I will pass the baton over to you.
Excellent. Thank you for that introduction and welcome everybody. I'm always really excited to give these presentations, especially over the last few years, because there's just been so much going on in this field. And a lot of that, I think, is because of people coming together. It's, patients, it's physicians, investigators, and of course, industry as well. I think everybody has come together and really are working to move this field forwards, which I think is really, really great. So let me see. So these are my disclosures. So what I'm going to cover today, I'm really going to go over sort of understanding the epidemiology, a little bit about risk factors, understanding the stages of bladder cancer, the current management, and some new developments and future directions. And just across the timeline here, you see some of the developments that have happened in this disease. And what you can see is early on, 1978, there was cisplatin, which remains a really important drug in this disease. There's MVAC in 1985. You've got gemcitabine cisplatin in 2000 and Dostensemvac in 2001. And then there was a huge pause in development up until 2017, when we saw the introduction of the immunotherapy or immune checkpoint inhibitors. People call it all sorts of different things, but it's sort of a new immunotherapy, followed by Erdafitinib, which is a targeted therapy. So by understanding what's helping these cancers to grow and targeting that, sometimes we're actually able to slow the cancers down. And finally, a drug called Enfortumab Vedotin, which is what's called an antibody drug conjugate. So again, as we understand the disease better, we're able to design drugs that target better. So this drug has an antibody that sticks to aspects of the cancer. We've got a linker molecule and then a bit of chemotherapy that comes along. So it's kind of, brings the chemotherapy to where we want it to go. And so I'm going to go into a little bit more detail about these drugs later on, but we're just going to start with some basics. So first off, bladder cancer, it's the 5th most common cancer overall. And in Canada, 12,500 new cases and 2,600 deaths occurring. Those are 2021 figures. The average age of diagnosis is 73, which is really, really, really important because it means that many patients are going to be older. They're going to have comorbidities, which may not only affect their ability to tolerate treatment, but also even to just handle the disease. And I think that's a really important point to keep in mind. So it's really critical that we look for treatments that are well tolerated, that patients can take and handle. The ratio for men to women is about 3 to 1. And I don't think we fully understand why that is, why there's more men having this disease and women. At one point, we could say that it was related to maybe smoking, but even that doesn't really hold true anymore. So it suggests maybe there's some biological underpinnings there, maybe related to hormone receptors or something like that. So what we know about this disease is that it can arise anywhere along the urinary tract. So from the mouth of the kidney through to the ureter and subsequently down to the bladder and even the urethra. That's where this disease can occur, but mostly occurs in the bladder, like 90% or so occurs in the bladder. And so that's why sometimes when we talk about this disease, we don't specifically say ureteric cancer. We talk about urothelial cancer, which defines the cells of origin from all of these locations. And because many people with upper tract disease are not necessarily studied separately, we include that all in our urothelial cancer trials. So from a histological standpoint, which means that how the cells look under the microscope, most of them are called urothelial, and they can be mixed, meaning you can have two different populations of cells, sometimes urothelial and squamous or urothelial and sarcomatoid. We believe that they probably behave the same as the pure urothelial, but that's an area of active research. The other challenge here is that these, and you can get pure variant histology, so no urothelial at all, but just pure sarcomatoid or pure squamous, pure adenocarcinomas, and those often show different behaviors, and those often aren't included onto clinical trials. We try to keep the trials pure, but what happens is, you know, you have a group of patients who have disease that may not be included, and so we end up extrapolating. When we look at the risk factors, certainly being male, increased age, it's a disease of older people. From a racial standpoint, Caucasian more common than African, more common than Asian. Smoking is one of the biggest risk factors for this disease. And I'm always surprised that when people think of smoking related cancers, they think about lung and they think about tongue and mouth, but they rarely think about bladder cancer. And even when you look online, you know, I think we have to do a better job of letting people know that smoking is a major risk factor for this disease, probably because some of the toxins end up collecting in on the bladder and then interacting with the wall of the bladder, resulting in changes. A couple of other things like aromatic amines, chronic bladder irritation. So patients who have ongoing inflammation, maybe they're having a catheter, we have to be aware that this is a risk. Certain chemotherapy drugs used to treat other cancers like cyclophosphamide, ifosfamide can increase the risk. Prior pelvic radiation therapy. So basically, if patients have had radiation for prostate cancer or some of the gynecological malignancies, that could put them at risk of secondary bladder cancers. Arsenic, and having one urinary tract cancer puts you at risk for another. So it's important to keep that in mind. And then there's also aristolochic acids, which are found in herbal products, may increase your risk, and more for upper tract than lower tract. There's a number of possible risk factors you can see there. There's work being done in terms of genetics. Are there certain, you know, sometimes you see that there are families that have, you know, some of these cancers. We haven't found a clear genetic link just yet. You know, what about living close to oil refineries? These are all question marks. E-cigarettes, we don't know. What about some viral etiologies like HPV virus? But the big thing really message here is that smoking increases the risk about 3 times and accounts for about 50% of all bladder cancers. So at presentation, the most important thing by far is really depth of invasion into the bladder wall. That is by far the most important. When people are diagnosed, about 70% will have non-muscle invasive bladder cancer, which means that it's just, you can see it here in the figure here, sort of stage 0, stage 1, just on the inner layer, not going into the wall of the bladder at all. 25% are muscle invasive, and they could be PT2, PT3, PT4, and that's just indicative of how deep into the wall this cancer is going. And finally, about 5% are metastatic at the time of diagnosis, which means they're spreading beyond the wall of the bladder or potentially even to other organs, the most common ones being lung, bone, and lymph nodes for this disease. So how do we assess these patients? Well, we start with the TURBT, or transurethral resection of the bladder tumor, and we also do CT scans of the chest, abdomen, and pelvis. And I think it's really important to get and ask for a CT scan, especially of the chest. Sometimes the chest gets left out. But if you remember, I told you at the outset, one of the big risk factors for bladder cancer is smoking. And so smoking also can, you know, increase the risk of lung cancer. So it's important to get a good picture of the chest. And I do that with a CT scan. Sometimes I found second primary. So, you know, it's really important to know ahead of time what you're dealing with. One of the problems in bladder cancer, unfortunately, is understaging, which means that what you see when you do the scan is not necessarily what you get at the time of surgery. So understaging can happen about 30% of the time, and can explain why sometimes what we think you're going into surgery with is not what comes out, and that's not uncommon. We are working on novel imaging strategies like PET scans that look more at metabolic activity. I have a fairly large trial that's going on across Ontario that will hopefully close soon, meaning it's met its accrual targets, and maybe we'll get some answers about whether adding PET scans to standard CT may improve the detection of bladder cancer. And if we have a better sense of what we're starting with, maybe we'll be able to treat it better. And in one study, PET scan actually changed the treatment plan for about 27% of patients with high-risk disease. So this may ultimately one day impact on outcomes. All right, so here's like an overview of the different sort of, types or settings of this disease. So NMIBC stands for non-muscle invasive bladder cancer. It used to be called superficial disease, and they got rid of that name because superficial is like, it's no big deal, it's superficial, but it's not quite so easy to pass it away, pass it off. So I think that this is the official name is non-muscle invasive bladder cancer, and it can be divided into low grade and high grade just based on the appearance under the microscope. And we really depend on our pathologist to give us the read on that. And these are treated with TURBT plus or minus BCG. And BCG is introduced directly into the bladder. It creates a bit of an inflammatory response. And in doing so, it's meant to go after the cancer cells that are there. To be honest, even though this has been around for many, many, many years, I don't think we fully understand why it works, but it works, so we use it. And of course, some of you may be familiar that there's been some BCG shortages, so they've been really careful in how this is used, very judicious use. And the hope is that that shortage will start to get better as new strains are brought into the Canadian setting. But despite BCG, some patients are not going to respond. So they're called BCG refractory. Their disease is not going to respond. And in patients who have BCG refractory disease, usually we're starting to think about cystectomy. So that means removal of the bladder before it has an opportunity to spread to other places in the body. So you also have something called muscle invasive disease. And this is about 25 to 30%. And this is very high risk disease. So it's localized. It stays usually for the most part within the bladder, but we know the risk of recurrence, even if the bladder is removed, is upwards of about 50%. So it's pretty high risk. So in this group of patients, I always offer neoadjuvant chemotherapy, which the goal of this is really to go after the local disease, but perhaps more importantly, is to go after the micrometastases, the disease that's trying to get away and trying to spread to other places. So wherever possible, I offer neoadjuvant chemotherapy. And most patients do quite well. And some patients even get what's called a complete pathological response, which means at the time of surgery, they see no evidence of cancer whatsoever. And we know in those patients that their overall survival is better. So really, really important, if you know of someone diagnosed with muscle invasive disease, to get them to ask their doctor about neoadjuvant chemotherapy. Now, what can we do locally? Well, certainly the gold standard for a long time has been removal of the bladder. Well, there's a problem, let's take it out. But removal of the bladder is associated with significant, what we say, morbidity and mortality. It's not fun to not have your own bladder. And people say the best bladder is your own bladder. So there have been a number of strategies that have evolved to try to help people to keep their bladder. And this is called trimodality therapy. So in our practice, not everybody gives neoadjuvant chemotherapy before, but what trimodality therapy involves is first, there's a maximal TURBT where they take out as much of the tumor as they can. And then we give a combination of radiation daily over 6 weeks, not on the weekends. And once per week, we give a little dose of chemotherapy just to make the radiation work better. And in a number of studies, head-to-head studies, but we can't really randomize people to having their bladder or not, in sort of looking at these two groups of patients, they're coming in that both of these are fairly equal in terms of outcomes, which I think is really great news for our patients. The only caveat is patients need to be selected carefully. So patients who have what we say multifocal disease, so disease dotted all around the bladder, may not be the best candidates for trimodality therapy. So there are some caveats, right? So, but it's important to ask, if your doctor is saying, well, you need to have your bladder out, it's important to ask, well, are there any other options? And can I see a radiation oncologist, if only just to get that opinion? And then in patients who don't get neoadjuvant chemotherapy, I'll absolutely offer adjuvant chemotherapy in the with the thinking that we're going to go after any cells that are stuck there that haven't gotten removed with surgery. And then we move into the metastatic setting. So this is when the disease has left the bladder, has gone to other places in the body. And right now, we still can't say that we can cure patients with metastatic disease. So although it is incurable, it remains treatable. So there's subtleties there, but basically it means that we have options. And as you saw from the little timeline on the first slide, we have more and more options than we used to have ever before. So I'm going to go into more detail, but this gives you a bit of an overview. So for patients who are considered cisplatin eligible, and there are criteria around that, I think the criteria are a little stringent. So we actually give people a little bit more leeway, just because, as I mentioned, patients can be older, their kidney function may not be perfect, but we can still get these drugs in because they are good drugs. So gemcitabine, cisplatin, followed by this maintenance approach with Avelumab in patients who have a response up front. So, and then the patients who can't get cisplatin can get carboplatin, which is a little bit easier on the kidneys. And the same thing, gemcitabine plus carboplatin. And the star here is just for patients who don't progress on first-line chemotherapy. They can get the option of Avelumab. And then in the group who can't get any chemotherapy at all, and in my practice, it's a very, very tiny group, if at all, they could be offered immunotherapy, but in Canada, we don't have approval yet for that approach. In fairness, chemotherapy has a much better response rate than immunotherapy in the frontline setting. So this approach of either gemcitabine cisplatin followed by maintenance immunotherapy, or gemcitabine and carboplatin followed by maintenance immunotherapy with Avelumab again, is actually probably better if we can get it in compared to just immune checkpoint inhibitors upfront. Then we move to patients who are what we call platinum resistant. So let's say they didn't get the Avelumab, because Avelumab is relatively new. Then in the second line setting, they would be offered an immune checkpoint inhibitors. I'll go into more details as well about this. And then beyond immune checkpoint inhibitors, in the past, we had chemotherapy called taxane, or another one called vinflunine, not used here, it's more used in Europe. But then, and now we have some novel therapeutic strategies, such as the FGFR inhibitors, which is a targeted therapy, or Enfortumab Vedotin, which is an antibody drug conjugate. So let's back up a little bit, talk about muscle invasive disease. So this is an aggressive chemosensitive disease where almost 50% will develop metastatic disease. Neoadjuvant chemotherapy, we know, improves outcomes, has shown a survival benefit. And although uptake is increasing, rates are still low. But the reasons for this are not entirely clear. We have the data, we know this works, but why are people not getting it? And in some cases, it's just, oh, let's take out the bladder. Oh, you don't need chemotherapy. There's numerous reasons why. But I think it's really important, as I'm speaking to you guys as patients to some extent, that you ask about that. It's important to empower patients, I think, to ask these questions. What about neoadjuvant chemotherapy? And so to better understand why the rates were low, we conducted a few surveys a few years ago. And what we found was that the uptake of neoadjuvant chemotherapy was actually better when all the doctors were working together, the urologists, the medical oncologists, radiation oncologists, when they're all talking, when they're discussing cases, we found the rates of neoadjuvant chemotherapy used to be higher. And I think that's really important. So if someone's been diagnosed with muscle invasive bladder cancer, my advice to them is ask to see a medical oncologist, and maybe even ask to see a radiation oncologist to see if sparing the bladder could be an option. So when we think about multidisciplinary care, it can be done in different ways. So we actually did a study to understand this. So in some cases, it's sequential visits. So the patient will see the urologist, and then an hour later, they will see the medical oncologist. Sometimes you see everybody together. I know at our center, patients sometimes will see the radiation oncologist and the urologist all in the same clinic, which is kind of neat because you know what the other person is saying. It's not like the urologist says, let's take out the bladder. The radiation oncologist says, let's radiate, and the patient's left trying to make the decision. What's interesting is that the main barriers to multidisciplinary care, and this was a Canada and US study, were things like lack of clinic space or funding or getting all the, coordinating everybody together and time, but not provider enthusiasm. And I think this is really important. I think people want to work together and we learn from each other. So I think it's really important as well to understand the patient's perception of multidisciplinary care. And we have some work, research going on in that area. All right, so for muscle invasive bladder cancer, we start with neoadjuvant chemotherapy and then can consider either radical cystectomy or bladder sparing. And appropriately selected patients really should be offered the opportunity to discuss the various treatment options. All right, so moving on to metastatic disease, we know that first-line treatment remains cisplatin-based chemotherapy. And basically, this chemotherapy goes in and prevents the cells from dividing. So all cells go, and when they're trying to divide and make more cells, they have to basically duplicate the DNA, and then the DNA needs to move to the ends of the cell, so then you can break off into two cells. Cisplatin basically stops that from happening. And so the cell can't divide, and many cells will die as a result. So in this way, chemotherapy can kill quickly growing cells, such as the bladder cancer cells. So with bladder cancer, they show fairly high response rates of 45 to 60%, but the challenge here is cure rates remain low. So there's some small percentage of cells that stick around, develop resistance, and over time, come back and cause trouble. So when we talk about, just to give you a sense of numbers, when we talk about response rate, that means a shrinkage of the cancer by 30% or more. So that's about 45 to 60%. MPFS is median progression-free survival. So if we take everybody in the study, how long is it before their disease starts to grow again? So that's median progression-free survival. How long are they before the disease starts to grow? And that's about 7 to 8 months or so, as you can see there. And MOS is median overall survival. So if we took everybody on the average, how long are people living? So first-line metastatic disease, just about 12 to 15, 14, 15 months or so. So just over a year. Now that's an average. So you can get some, I've had some patients who do not live that long, unfortunately, who have lots of disease in their liver, lots of disease in their lung, are very frail, are very weak, can't take treatment, and their life expectancy may be a lot shorter. But optimistically, I have other patients who've been upwards of 5, 6, 7 years by going from one treatment to the other, clinical trials and the like. So there's a huge heterogeneity in terms of how long people with this disease will live. What we do know is ultimately, though, we don't have a cure, okay? The other consideration is this assigning patients as being cisplatin unfit, which basically means that, you know, someone has said that they can't get cisplatin-based chemotherapy. And that's important because cisplatin-based chemotherapy is pretty effective. You know, in our world, 45 to 60% is pretty good. It's not 90%, I get that, but, you know, it's important that patients get access to this drug. But things that determine cisplatin eligibility, most importantly, are kidney function, and that we measure something called creatinine. Things like if they have heart problems, if they're up and out of bed, or if they're in bed all the time, called performance status. They have neuropathy, so a lot of tingling in their fingers and toes. So these are the things that we use to assess if a patient is eligible for cisplatin or not. And I think at the same time, we have to keep in mind that this is an incurable illness, and we do want to give people the chance of getting the best outcome. So, you know, I tend to push a little bit in terms of giving cisplatin, and you know, we see how they do. And if a patient does well, we keep going. If not, we make some adjustments, maybe flipping to gemcitabine and carboplatin. So we know, though, that there's an unmet need in the sense that not everybody will respond. And amongst even those who do respond, at some point, the disease becomes resistant. So what's immunotherapy? Well, I have a slide coming up in a minute, but immunotherapies that had a really big impact in bladder cancer. But perhaps the biggest impact is that it's opened the door for clinical trials. So up until immunotherapy, you saw how the trials were kind of stalled for a period of time. Once immunotherapy came along, it ended up representing a well-tolerated treatment. We as a field were able to get these trials done. We were able to put patients on the trials, get the trials done, and drugs were getting approved. So the rest of the people, you know, industry and people who are developing new drugs said, well, hey, you know, I could do a trial in bladder cancer, and this could lead to a drug being approved. I'm going to go look at this now. So I think it really opened the door for clinical trials in that way. Now, immunotherapy itself is not really a new concept in this disease. The drugs are new. But if you think about it, BCG is kind of stimulating the immune system, so that concept has been around for a long time. So how does immunotherapy work? Well, basically what happens is we understand that the cancer is there, and the immune system, the T cells, come in and try to attack the cancer. But what the cancer does is it shuts the T cells off. It's like it turns off the switch. And these off switches are there naturally in the immune system, because if you've got some infection and the infection is gone, the immune system needs to naturally be able to turn itself off. The problem is cancers have sort of taken over that off switch mechanism. So in the cartoon here, you can see that tumor cells bind to T cells to deactivate them. So it kind of goes, shuts down. The tumor cell here shuts down the T cell that's shown here in red. Immunotherapy type drugs block that shutoff process. So they can either block at the site of the tumor cell, where I kind of joke and say it's like blocking the finger that's going to turn the switch, or it can block at the side of the switch, where it's like putting a tape over the switch so the switch can't be turned off. So in this way, you're sort of stimulating the immune system to re-recognize the tumor. And there's a number of different types of immunotherapy drugs, mostly targeting one pathway called the PD-1, PD-L1 pathway, or the CTLA-4 pathway. And these drugs that do this are all slightly different, made by different companies. And so they all are being tested and used in different settings. But we do tend to be fairly loyal to how a drug was tested. And if one drug was tested in a certain setting, that's where we tend to use it. That's where it's approved. We don't tend to mix and match, even though I really think that these drugs have probably more similarities than differences. All right, so what's new by way of immunotherapy in the first line setting? So you remember I told you that chemotherapy is pretty effective. About 45 to 60% of patients will have a response. And there's another portion that will just have stable disease. A small proportion of patients, maybe 20% or so, will have progression. But in the bulk of the patients, in 70 to 80% of patients where chemotherapy, platinum-based chemotherapy, so that's the regimen called Gem-Cis or Gem-Carbo, is going to put the disease to sleep, in some cases even shrink it. But the problem is one of durability. So this may not last for a long time. And these cancer cells, some of them start to wake up again and start to grow. So the Javelin Bladder 100 trial basically took patients who did not have any disease progression on frontline chemotherapy. So what we call a complete response, a partial response, or stable disease. So CR/PR or stable disease after 4 to 6 cycles of chemotherapy. And these patients didn't have any surgical options. So basically they had disease that was kind of stunned or shrinking. And they took half the patients and gave them an immunotherapy called Avelumab. And this is given intravenously every 2 weeks. BSC is just best supportive care, or best supportive care alone, or they just followed them. And the best supportive care alone approach is what we used to do. We used to give chemo and then watch. And that's why ethically this study we could do it, because we didn't know if giving Avelumab, if giving something made a difference or not. So in our minds, what we say, there was equipoise. Maybe it would work, maybe it wouldn't, we didn't know. The primary endpoint was overall survival. So we were trying to see if the patients who, in the blue arm, the patients who got the maintenance of the Avelumab, did better than the patients who were just observed alone. And what was found in this study really was the group that got the maintenance of Avelumab, the immunotherapy to keep things at bay, had an overall survival of about 21.4 months, compared to about 14.3 months just doing it the way we regularly do it. The safety profile of this drug was reasonable. With immunotherapy, you can get things like rash and diarrhea and can affect your thyroid, but we've gotten a lot better over the years in managing these toxicities. And for the most part, these are well-tolerated drugs. And it's really important just to mention here that we're still all learning though. And it's important that if you're on immunotherapy, that you let your doctors know what side effects you're having. Occasionally you can get very severe side effects. In any case, so with this benefit seen of about 6 months or so, this then became approved by Health Canada. So basically this study showed that you do chemotherapy in people who have a good response or at least stable disease, the next step for them is to get Avelumab immunotherapy. So this is Health Canada approved. We are doing this in the clinic. And I think, it's a really nice thing to offer patients because you're not just waiting for something to happen. You're actively trying to prevent the disease from continuing to grow or at least delaying that. All right. So what about patients who do not have disease response to frontline chemotherapy, or those who had disease progression after frontline chemotherapy? So let's say they never received Avelumab. What are the options in that case? So typically in the second line setting, we used to do what you see here in the burgundy box. We used to give chemotherapy. Most commonly, I would give paclitaxel, which is a chemotherapy that works in a very different way than the cisplatin chemotherapy we did in frontline. So you're kind of trying to attack the cancer from another way. So this is what we used to do in the second line setting. So this study that was called the Keynote 045 study compared a different immunotherapy called Pembrolizumab, it's a PD-1 inhibitor, against paclitaxel chemotherapy, okay? And so when you compare the two of them, what they found was there was about a 3-month improvement in survival, 10.3 months for the group who got Pembrolizumab versus 7.3 months for the group that got paclitaxel. And so based on this survival benefit, again, this drug was Health Canada approved. So the idea is if a patient doesn't have disease response with frontline chemotherapy, you would then go to Pembrolizumab, which is immunotherapy in the second line. However, if they have received maintenance of Avelumab, you would not go to Pembrolizumab because they're both immunotherapies. So if they've progressed on one immunotherapy, it doesn't make sense to go to a second immunotherapy. Okay, so that's sort of what's happened in the second line setting. Now, what about in second or third line? And I told you at the outset that we are learning more about these cancers all the time. And we have learned that something called the fibroblast growth factor receptor, basically it's something that sticks up from the surface of the cancer cell. And it's like it gives a signal for the cancer cells to grow. And this receptor is present in about 15 to 20% of bladder cancers. It's not there in everybody, but about 15 to 20% it's there. And sometimes what happens is it's working overtime to drive these cancers. So the cancers will grow and divide more and more. And many different reasons for that, but it then makes sense that, well, it'd be ideal if we can block that signaler, if we can block that receptor. So there's a number of drugs now that target, you see it in the blue circle here, that are aimed at targeting that receptor. So the drug Erdafitinib was tested in this BLC 2001 study. So this took patients with metastatic disease who had prior chemotherapy, and they carried an alteration in their FGFR receptor. And then they were randomized to 2 different dosing schedules of this drug. And it's an oral drug. It's the first oral drug we've had in this disease. And what they found was the response rate was about 40%, which is actually quite respectable given that these patients already had 1 or 2 lines of treatment. The progression-free survival about 5.5 months, so it stopped the disease from growing for about 5.5 months. The overall survival was 13.8 months, and just over a year. And this drug was also Health Canada approved, really for patients who have FGFR alterations. The challenge we face with this drug, though, comes to the biomarker testing, getting those tumors tested for FGFR, because although it's Health Canada approved for the drug, the testing is not quite online yet. So there's been a lot of activity trying to say, well, if you're gonna approve the drug, we need to know if we can give patients this drug. At some of them, the academic cancer centers, the testing is available through various studies, but that's really sort of a work in progress. That's something that we're all trying to get on board so we can identify the 15 to 20% of bladder cancers. And the other reason it's important is that we now have more trials targeting this FGFR receptor, so identifying patients who have it becomes increasingly important. All right. And then what about third line? So this is another exciting development in the field. So this is for patients who've had disease progression on chemotherapy and immunotherapy. So Enfortumab Vedotin, this is a drug which targets something called nectin. So nectin is something that's highly expressed on many, many, many bladder cancer cells. So it targets nectin. It's got a little linker molecule you can see here. And then it brings the chemotherapy right into close proximity of the tumor. So it's kind of bringing the chemo where we want it to go. So it's a really clever way of getting chemotherapy to these cancers. And we know the chemotherapy that's used in this drug is sort of similar to the taxane. So we know that mechanism of action works, but this drug It's called an antibody drug conjugate, and there's other such drugs that are coming down the pipeline as well. So this was the EV301 study. And so this took patients with metastatic urothelial cancer. They had progression of their disease following chemotherapy and immunotherapy. So, now we're in the third line setting. Their ECOG performance status was 0 1, meaning, they had to be doing quite well. And you'll notice that on trials, they tend to limit patients who can go on the trials. They don't want someone who can't get out of bed, who can't come into the cancer center. They want people who are relatively well. And so patients on this trial received Enfortumab Vedotin, which is really given weekly for 3 weeks intravenously, and then 1 week off. And they continue on treatment until there's disease progression. Or they receive the chemotherapy that we used to give, something like paclitaxel. So this is an important study. The primary endpoint on the study was, again, overall survival. And the reason why you're seeing how long people live or overall survival as such a critical endpoint is FDA, the Food and Drug Administration in the US, Health Canada, all look to see for an improvement in overall survival to give the drug approval. So that's what all of these studies are saying. Does this treatment really make patients live longer? That's really the critical question. Secondary questions include, does it delay the progression? Does it shrink the disease? And do people tolerate it? But the primary for a long, long time has really been overall survival. And if you look here on the right, overall survival, again, they met their endpoint, meaning the survival was about 13 months versus about 9 months, about 4-month improvement in overall survival. So I'd say we're sort of chipping away step by step by step and trying to help people live a little bit longer, a couple months at a time, right? So if you look at these drugs, each drug has an improvement in survival of a few months, and partially why we're seeing overall survivals in this disease extending from the 14, 15 months that I showed you at the outset, probably now why I have people, at 20 months or even beyond that. And if you think this is in the third line setting, patients have had chemo, they've had immunotherapy, and they still have overall survivals of about 13 months. And that's an average, which means that some people are living well beyond that. This drug itself is not badly tolerated. It can cause some neuropathy, which is tingling in the fingers and toes. But we also know, and we did some of these early studies to say that, well, even if you drop the dose, you can admit the tingling in the fingers and toes, which can be really annoying and quite a nuisance value for patients. Sometimes it actually affects the ability to do buttons and things like that. So we really want to avoid that. This can also cause some troubles with blood sugar control. So that's an important thing to watch for. And like any chemotherapy, there's always a risk of infection. And so if patients get fevers while they're on these type of treatments, it's important that they go to the emerge and seek medical attention. The good thing about this particular drug is that because nectin is so highly expressed, it doesn't need biomarker testing. You don't have to do any testing in order to get access to this drug, which I think really makes it a very attractive drug. And for the most part, this is where we're going in the third line setting. And really for all comers, this drug can have a true benefit. So I'm going to leave enough time for questions there. So as you can see, there have been many novel approaches that are being explored. In the metastatic setting, we're starting to see combinations. So what about combining immunotherapy and targeted therapy, or immunotherapy and antibody drug conjugates? Interestingly, they have looked at combining immunotherapy and chemotherapy, and we haven't quite seen the bang that we wish we did. And we don't fully understand that yet. But this is sort of where the future is. Outcomes are definitely improving. My waiting room is a lot busier now, which is sort of exciting in a way, because it means that patients are there longer and living with this disease as we try to turn it more into a chronic disease. I think it's a super exciting time in the field, and we're super dependent on accrual to clinical trials to keep these stories going, to keep asking questions, answering those questions. And I think there's both positive trials, but we learn a lot from the negative trials as well. And maybe it's not fair to call them negative trials, but trials that don't lead to a new drug being approved. It just tells us that maybe we need to go in a different direction. But overall, I think it's been a really, really interesting and exciting time in the field of bladder cancer. You have many more options. I think it's really important that you talk to your doctor, ask a lot of questions, always ask about clinical trials. If need be, ask for a second opinion. Sometimes it's even just, you know, to have someone go, yep, I agree with what you're getting at your cancer center. So I think with that, I'll stop, and I'm happy to take any questions.
Great. Thank you so much, Dr. Sridhar. That was amazing. A lot of information. I was scribbling down my notes with other questions to ask when I can get you offline. So if anyone has any questions, please use the button at the below and raise your hand, or feel free to mention something in the chat as well. So I see Matthew Yeager. Would you like to go ahead?
Yes, I entered a clinical trial with Durvalumab, and I see you don't mention Durvalumab, but I'd like to know what is the relationship between Pembro, Avelumab, your new targeted Enfortumab, and Durvalumab. Where does everything sit? Because right now I'm coasting and occasionally drinking a martini.
So basically, Durvalumab is very similar to Avelumab. So it is what's called a PD-L1 inhibitor. So they're part of the same family. And if you remember, I said many of these immunotherapy or immune checkpoint inhibitors have more similarities than differences. So it's just at which point do they block that immune system and the tumor cell interacting? Are they blocking at the tumor side, or are they blocking at the immune system side? And so Avelumab and Durvalumab and another one called Atezolizumab are all called PD-L1 inhibitors. And they have very similar response rates to the PD-1 inhibitors, which are Pembrolizumab and Nivolumab. So very, very similar drugs. Now the other drugs, the Enfortumab and Erdafitinib, those have different types of action. So they work differently. So Erdafitinib is a targeted therapy, and Enfortumab is sort of a targeted chemotherapy, an antibody drug conjugate. So although the immune checkpoint inhibitors, the ones, the PD-1, PD-L1s, are not used interchangeably necessarily, their mechanisms of action and the response rates are all in the same range.
Thanks, Kala. That's just, I'm just, my head's swirling, trying to take it all in. And my question is maybe simple, because I had muscle invasive bladder cancer 10 years ago. So I always consider myself, you know, done. I'm a neo-bladder person and have had remarkable quality of life. And I guess I underscore quality of life in all of this. So, you know, with all of these drugs, unfortunately, I was one of those renal complicated patients that didn't tolerate cisgem very well. Like, can you just make an overall comment? Like, do people live well, you know, with metastatic disease, with all of these drugs on board, with all of these combinations? Like, it just sounds like chemical warfare. And I just know that I didn't do well on the drugs side, and again, because of renal issues, but how well do patients really do with that quality of life aspect?
I think that's a great question and a great comment. And I think more and more we're trying to incorporate this quality of life question into our clinical trials to answer that precise question. So as a group, the immune checkpoint inhibitors, the PD-1, PD-L1 inhibitors that kind of train your immune system to re-recognize the cancers, they tend to be really well tolerated. The main side effects are things like rash that we can manage with a very low dose of steroids. Some people get some diarrhea. And other than that, it's quite easy. Some people have some fatigue, some thyroid issues, but I think over the last sort of 5 years or so, while we've been using these drugs a bit longer from clinical trial days, we have gotten better at managing these drugs as well. So we can give patients breaks, we can give them a little bit of steroids, some steroid cream. So that class of drugs as a group is actually fairly well tolerated. And we have some work that we're looking at right now. We're trying to ask this question because we've had a few patients that have had more toxicities, like they've had, you know, some people have had inflammation of their lungs a little bit or bad diarrhea, but there may be a bit of a silver lining, and some of these patients may actually respond better. So we're just doing some studies now to understand that better. But overall quality of life on these treatments are quite good. And I have some patients who say, am I getting anything at all? I don't feel like I'm on anything. So that's always a good thing to hear. When we look at the Erdafitinib, that's not a badly tolerated drug. It's given orally. The main side effects there are nail changes, which just is like, it's like nail changes, but they can be really troubling, maybe even a bit more for women than men. Maybe that's a bit of a gender statement, but I do feel that can be sometimes difficult. And I think the way to address some of these toxicities is with dose adjustments, giving breaks, like recognizing that it really needs to be a good balance between quality of life and efficacy. And I know sometimes patients don't want to report symptoms because they're like, oh no, you're going to take me off treatment, or you're going to drop my dose, and I want it to keep working. But it really has to be a balance, because if it's working, patients may be on these drugs for a very long period of time. So that's really important. And then the other one to think about, so the Enfortumab, again, well tolerated, but neuropathy can be an issue, especially because, you had the gemcitabine cisplatin, there can be neuropathy from that. There can be neuropathy from, chemo, and neuropathy again from Enfortumab. So it's again, really, really important to report these side effects. So we can do some dose adjustments, dose delays, dose breaks to help people get through. But I have some patients who are, third, fourth line who continue to be working through their treatment. So it gives you a sense that they are relatively tolerable treatments and developed as such.
Yes, Dr. Sridhar, here's one for you. Patient does well on Durvalumab starting in 2018 with a monthly infusion. The patient is now off the monthly infusions and approaching the 2-year mark. However, if there is a sighting by a CT scan of a resurgence of cancer, the question I have for you is, do you put the patient back on Durvalumab where he did fairly well? Do you switch him?
That's a really facing recurrence in one area. What I would do is I would actually ask my surgeon and my radiation oncologist if they could potentially go after the localized recurrence. And, it's within their purview to say, well, no, it's too close to some structure or something. But that's one thing. I always keep that door open, number one. Number two, I think if it's a small progression, not big disease, then I might put them on Durvalumab and follow very closely. So probably think about doing a CT scan again at 6 weeks or 8 weeks, because if the disease is stable, I would maintain. But if the disease is progressing, then I would go to Enfortumab, or I would look for any available clinical trials, or, at the same time, I'd also test for FGFR. So then I would know is, if they're FGFR, if they have an alteration in FGFR, maybe Erdafitinib. If they don't, Enfortumab, or potentially a clinical trial. So that's sort of how I would approach that. I would look at where the recurrence is, how much disease is recurring, or how much is there. I'd look for a local option if possible. And if not, I'd consider, restarting. I'd consider Enfortumab or consider Erdafitinib. So all those options are on the table, including clinical trials. All of the options are on the table. And the thing is, I will say that we don't have a lot of sort of sequential data, meaning you must do Durvalumab, Enfortumab, and then Erdafitinib versus, Durvalumab, Erdafitinib, and Enfortumab. We don't have the granularity yet to say which is the best approach.
Thank you, Dr. Sridhar, for your time, for all the effort you put into the slides, and for explaining it so well. Really appreciate it.